All right, we're live.
All right. Good morning, everyone. This is the Senate Health and Welfare Committee meeting, and it is February 16th. And we're joined today in committee by Senator McCormick, who's going to give us his introduction to S74. So Senator, thank you for being here today, and we appreciate that. So we did have a run through of the bill just briefly last week, but we felt it really important that you as lead sponsor be here to give us the reasons for the bill introduction. So.
Thank you, Madam President. I have submitted.
Oh, I just got promoted, but I'll take
Madam,
it.
I'm sorry. Madam Chair, I've submitted written testimony, but I think I'll speak more spontaneously. First, it's good to be back in the committee. I served on this committee for many years with Senator Cummings and with the chair under at that time, the chairmanship of Senator Claire Ayer, who's successor from Addison County is now on the committee. So there's certain continuity here. I had been out of the Senate for several years as a private citizen before coming back and serving on this committee. And during that time, much of the work I did was as a private, in the private sector as an organizer on the same issue of patient choice at the end of life. And I think the best work we did during my time on this committee was getting that bill, the patient choice bill, passed. We modeled the bill, which is now the law, on what was already an existing law in the state of Oregon. And the reason for that is that at the time that Vermont was considering this policy, it had already been the policy in Oregon for several years and had worked well. And much of the opposition, some of the opposition was purely philosophical, that the argument was that this is a choice for God, not for the patient, and so on. And those kinds of philosophical decisions devolved to the question, really, what is the proper role of the state? We have never made a judgment on whether it is moral or proper or good in the eyes of God to hasten death, but rather the matter for us was what is the proper role of government in the matter. And if there is the will of God is a question, well, then it's up to the individual patient and his or her beliefs. Am I being waved in?
Yeah. I voted against the bill, and you are not characterizing my opposition correctly. That wasn't the total. Just to be clear, there were other reasons to oppose the bill. That was one of them, but there were others.
That's where I was going, actually. I said that the philosophical reasons, ultimately we had to, the state made a choice. But the other widespread opposition, most of the opposition, and this is not to accommodate my friend Senator Cummings. This is, in fact, what is in my written testimony as well. The opposition was conjectural because we were going into something new, and just as the benefits were somewhat conjectural, so too were the opposition. What if there are greedy grandchildren hastening grandma's death so they can inherit sooner? What if the patient is superannuated and not really totally in possession of his or her faculties? What if the prospect of imminent death is so depressing that the patient really isn't thinking clearly? What if the patient is being pressured? And those what ifs were conjectural, but perhaps worthy of being taken seriously. Similarly, any benefits were conjectural, at least at the time that Oregon was considering their bill when they first passed it, because it was uncharted territory. And so they did not powerfully resist the what ifs. They responded to the what ifs with safeguards. And a major characteristic of the Oregon law was that it not only provided a dying patient with the option of hastening death at his or her choice, it provided a body of safeguards, various steps that had to be taken before that could happen. And those steps were all designed around the perceived problems. And indeed, those same conjectures were raised in the Vermont debate. And the response of those of us advancing the bill was to allude to those safeguards. Now we're several years down the road, and the law, both in Oregon and in Vermont, and now in several other states as well, has been that the law has worked well, that the perceived problems have not presented themselves, and largely it's because of those safeguards, or at least the safeguards, as the term safeguard implies, guarantee that the feared problems not present themselves. What this bill does is it responds to the experience of the several years that this has been the law, to identify some details of mechanizing these safeguards that do not have been shown to not be necessary, and in fact have been shown to make it more difficult for a patient to fully access the benefits offered by the law. Would you like me to go through the bill, or I see that Jen is here, who drafted it? I presume the other one. If you want to have, I will get into the details if the chair prefers.
I think rather than get into the specific details, if you could give us kind of the thumbnail sketch of what the bill does. I know there are about 3 very important changes made to the process. And so if you could just give a highlight of those, and then when we go through the bill, we'll identify them again with Jen.
Okay. Section 1 removes the requirement that a request for a prescription be made in person, allowing for requests to be made via telemedicine when appropriate. This requirement, I point out, telemedicine was not even on the table when we passed this. I guess it was talked about in theory, but it was not in legislation, it was not in law. This requirement has been burdensome to very sick people for whom it's difficult to go physically to a doctor's office. By removing the requirement that the patient's oral requests are made, quote, in the physical presence, quote, of the doctor, the law would align with best medical practice, allowing telemedicine when appropriate. Currently, Vermont is the only state in which physical visits are required for aid in dying. In all other areas of medical practice, Vermont law allows the use of telemedicine based on medical judgment and standards of appropriate practice. The bill also removes the requirement that the prescribing doctor, him or herself, do a physical exam when the doctor is able to make the necessary and required determinations through telemedicine and clinical review. Telemedicine was only a theory, or I'm reading my prepared remarks, I'd already written that. Section 2 clarifies liability protections, but Section 1 also makes a slight adjustment in the Act 39 timeline. The proposed amendment keeps the mandated 15-day waiting period, but removes an unnecessary and burdensome additional 48-hour delay period after the second oral request, the last step in the process before a prescription can be written. The additional period creates an added burden for those individuals who have already invested a significant amount of energy in the process during a very difficult time. The total of the 15 days and the 48 hours makes Vermont's Act 39 timeline one of the longest among the 10 jurisdictions that have these laws. The amendment would delete the 48-hour delay. Section 2 clarifies that acting in accordance with the law would protect all parties involved in its use from claims of liability. Current law explicitly provides immunity only for doctors involved in the process. The Attorney General's office has opined that immunity for other providers involved in Act 39, and specifically pharmacists, is implied in the law. However, some pharmacists in Vermont are not satisfied with implicit immunity and have required doctors to sign onerous indemnification agreements prior to filling prescriptions for their patients. Other state laws, immunity, and have required doctors to sign onerous indemnification agreements prior to filling prescriptions for their patients. Other state laws, immunities have required, I'm sorry, I'm getting lost in my text. Other state laws covering these laws provide immunity for all persons who comply in good faith with the law. This amendment makes what is implicit explicit. So that's the bill.
Thank you. Just so what I'm hearing you say is that the provisions, the proposed changes in the bill help to bring Vermont law more in line with what other states are currently doing. Would that be an appropriate characterization?
In line with what other states are doing, also somewhat updating. Telemedicine, as I say, was something talked about in the halls, but it was not in law, it was not in legislation. We did a lot of telemedicine just very recently. And to remove unnecessary impediments to the patients.
Okay, thank you.
Yeah.
So questions for Senator McCormick? Senator Hooker? No?
I
Okay.
do, yeah, I do.
Okay. You disappeared. Well,
I'm trying to use my iPad for the first time, so this is.
we'll be
different.
patient. Don't worry.
Thank you, thank you. So Senator McCormick, when you talk about telemedicine, obviously you're talking about video. We're not talking audio only, which is another topic that we're covering.
Well, I don't know if the bill explicitly says it, but that's certainly my understanding. Yeah, because I mean, if you're going to do an exam, you want to see something. But it also can involve just looking at the medical record as well. I mean, that's looking at what has already been researched, what are test results.
Mm-hmm, mm-hmm. But I guess I'd be a little concerned if audio only were included, looking at getting a sense of what Senator Cummings perhaps was opposed to in the initial bill, the types of things that could happen. So, and at some point, I'd like to hear from Senator Cummings about what your concerns were when the bill was first brought up.
So I want us to be very cautionary about going back to the underlying bill. If the concerns relate to the current proposed changes, then that's one thing. But I don't want to resurrect the arguments that were in place that for the underlying bill. Right now, I think your issue around audio only versus audio visual is a very good issue for us to bring up as we look at the bill. But I just want to caution us that this is not about, removing the underlying statute.
bill.
Yeah. So that might be a good conversation offline with
Yep.
Senator Cummings, but and I'm sorry to interrupt that thought, but I do think we need to stay focused on what S-74 does and what it does not do. So,
Thank you.
all right. Other questions for Senator McCormick? Senator Hardy.
Thank you. Senator McCormick, I'm just wondering if you have heard from people for whom these have been barriers, these various waiting periods or access issues, or if it's, you're just making the assumption that they are barriers.
No, when we passed the patient choice law, the people, the private citizens who had been organized in support of that policy formed an organization, which is End of Life Choices, and in Vermont, and they monitor the conduct of the law and the experience of people using the law. And they actually had raised the issue with me. So I would expect that the committee would hear from them at some point.
Okay, thank you.
Thank you. Yeah, exactly. That this is the beginning of our testimony, but we will have those folks in and others who have an interest in the bill itself. Any other questions for Senator McCormick? Wow. You did
Before
a
I
great-
leave-
See, you did a great job, Senator.
Thank
Thank you.
you. As a point of personal privilege, since I'm here, before I leave, I would like to say I am now 1 hour into the effort to get my COVID vaccine appointment. And the Health and Welfare Committee might want to lean on the Health Department a little bit to get a more workable system.
Well, you'll have a chance tomorrow to ask that question of the commissioner. I'm not sure that we can dive into all the software issues that exist out there. If we did, we'd be here all day, but your point is very well taken. There are a lot
Thank
of
you.
people who've had difficulty. Senator Terenzini.
Thanks, Senator Lyons. I was just going to mention, since you mentioned it, Senator McCormick, Senator Brock in our Republican caucus this morning was very frustrated as well. He had been almost an hour trying to get through as well. So it certainly felt in all areas of the state, it seems. So
Thank you for that. I don't feel so bad.
No, don't. That actually, when you think about it, it could be the good news with the bad news. The good news being that people are so interested in making appointments that there's a backlog. So, but we don't want to go there yet. We want to make sure that the system is totally functional.
In defense, I set up my thing yesterday and I got right in today. But I had trouble getting Regis registered in and he called and they had him booked in 5 minutes.
Telephone,
So-
good. All right.
I called and they told me to go to the website.
They did, the first time he called, they were not taking calls because they were
Yeah.
inundated.
I think it's variable. Today is the first day it's been open for 70 plus. And so I
Yeah.
think the first day is always hard. And, Senator Terenzini mentioned Senator Brock. He said in our committee in finance that when he went to get his shot, everything was really smooth.
Great.
It went really great. So it's obviously a mixed situation right now. Some people it's smooth and some people are having a harder time.
Regis is just getting his first shot as we speak.
Cool.
So he was further booked out because he was later getting in. I have one for next Tuesday.
All right.
Madam Chair, I apologize for getting this started. I just
No,
thought.
no, this is fine.
Part of the show.
Always.
No, I'm trying to get Regis registered. And even me, it would not take a password that met all their qualifications. It took me a while to find a password, put a lot of symbols in it, swear. That was the only way I got through. One symbol did not do it, along with one number.
All right. Well,
Thank you, Madam Chair. Thank you, committee.
thank you,
I remain
Senator.
available to you as needed.
All
Thank you.
right,
Bye-bye.
terrific. Okay, take care. So, Jen, I think, Jen Carby, are you there? There you are. So I think we have been through S74, but what would be helpful, I think, just for a few minutes, and then, because then we want to move on to the flexibility bill, to identify for us in the sections of the bill where the proposed changes are and remind us of exactly what they do. So we could pull that bill up together and look at the, and I think the outstanding question is on telemedicine. Is it audio only, is audio only allowed or not? So that's an important question.
Sure. Jennifer Carby, Legislative Counsel. So do you want me to put the bill up on the screen?
Yeah, that, I think
Is that
that's
helpful? Okay, great. All right, so you should be able to see it now. We'll go to the very beginning. So this is S74, and we'll go past the statement of purpose for now because we're really looking at the language. So as Senator McCormick had said, this gets rid of the requirements that these oral requests to the physician be made in the physician's physical presence. So it does not speak to what alternative modalities may be used if physical presence is not required. It doesn't speak to either telemedicine or audio only telephone or something else. It does have to be oral, so it would have to be something that the physician could hear, but it doesn't specify. And just one small clarification. There was actually the first telemedicine legislation had been enacted the year before this legislation was enacted, although this legislation, the patient choice at end of life legislation had been discussed in a number of previous bienniums. But actually when it ultimately passed, it was the year following the first year of the telemedicine legislation being enacted. So they did coexist, but I don't think it was nearly, telemedicine was not nearly as prevalent as it has been, and certainly since the pandemic. So if you are interested in looking at removing the physical presence requirement, you may want to think about whether there are certain parameters that you would want to allow, like audio and video together, or if you want to be less involved in that. I mean, again, thinking about the audio only language, there's a lot of emphasis on what's clinically appropriate. So it would have to be clinically appropriate to be doing this part of the process by audio only telephone if that was the choice that the provider had made. So that may weigh into your calculations as well. So that's the first piece, is taking out the physical presence requirement for the oral requests for medication. And then going along with that, the physician's determination that the patient was suffering a terminal condition, taking out the requirement that that be based on the physician's physical examination of the patient. So it's still based on some sort of examination of the patient and a review of the patient's relevant medical records. But it doesn't have to be a personal physical examination.
Well, but it does imply some kind of visual. I don't know how you have an examination. We'll have to hear from from folks about this.
Right. I think it would be important to hear from the medical community what they would determine to be the appropriate standard of care for an examination of the patient if it is not a physical examination. And then we have the that waiting period that Senator McCormick spoke about. This is that provision saying that the physician has to wait at least 48 hours after the last to occur of several events. And that includes the 15-day waiting period between the two requests, but taking out that 48-hour requirement after the last of those to occur before the physician writes the prescription. And then lastly, we have the Section 2 more general immunity, not specific to physicians, as is what's explicit in the bill. He was talking about making the implicit explicit. This is that language saying that no one would be subject to civil or criminal liability or professional disciplinary action for acting in good faith compliance with the provisions of the chapter.
I have a question here. Is this something that the Judiciary Committee in any way should look at as we're going through the bill?
That's a good point. I think they had looked when the original law had passed, I think they had looked a fair amount at the immunity language. So it might be,
Right.
you know, I will leave that up to you, either
Yeah.
officially or unofficially, to consult with the chair there and find out if that's something they would want to look at.
We'll do that.
Madam Chair,
Yes, ma'am.
may I ask a question of Jen?
Oh, no, go ahead.
So you mentioned the provision that's actually in our audio only bill, and I don't want to conflate the two too much, but it's kind of relevant to both, about the clinically appropriate. And I think that makes a lot of sense to have here as well, my own personal opinion. But I'm wondering, in both instances, is it the physician who determines what's clinically appropriate? Who makes that call?
Yeah, I think it's a good question. I think in the immediate timing, it would be up to the physician to, you know, in the moment, to make the determination about what's clinically appropriate. But I think that can play out in further events in a couple of ways. If there was a malpractice claim brought, they would probably be looking at whether it was clinically appropriate and what the appropriate standard of care is within the medical community, for whether it was appropriate to have delivered care in that way. And then also for insurance or Medicaid reimbursement, they could potentially decline to pay for something if they did not deem it to be clinically appropriate. And that's why there's, in the audio only language, some requirements for documenting, the physician or provider to document the reason that they thought it was that they determined it was clinically appropriate to deliver the services using audio only telephone, so that there would be that information immediately available if there was an audit or other exchange with the payers.
Okay. And speaking of payers, are the services provided under Act 39, these end of life services, are those covered by insurance or
I
not?
don't believe they are specifically required to be. So I don't think there was I'm just skimming through here. I don't think there is a requirement for them to be covered. So it may depend. And it may be that some of this conversation happens as part of, or these various conversations happen as part of a medical appointment that would be covered. And so some of the processes may be sort of inherently covered in that sense. But I don't know, for example, if the prescription medication that would be provided to hasten death is on a form, on the insurer's prescription drug formulary, such that the regular cost sharing would apply or not. That would be something you might want to hear from providers about, or from the payers about.
And there
What they
are specific rules regarding hospice care within Medicare that are different from.
Right, this is not
Medicare.
hospice.
No, but if the individual were in hospice, that would be different. So anyway. Or if they were in I'm thinking of a nursing home or other location. Okay, go ahead, Jen.
I don't have anything else.
That's it. We've got it all. Okay, so we do have some questions. I'll circle back with Senate Judiciary about the liability language so that they can review that on our behalf. And then we'll want to hear from End of Life Choices and others about the specific requests that are in the bill, specific changes that are in the bill. And we'll get that on the agenda sometime fairly soon. So any questions, other questions, committee members? All right.
Senator Lyons?
Yep.
I guess I need a clarification as to what's clinically appropriate. How is that defined? And I'd like to have some discussion about that, perhaps with some of the providers or whatever.
We can try to do that. You know, this is the clinically appropriate definition is one that gets, it becomes somewhat controversial. And so we'll try to at least address it a little bit, but I don't know that we're going to resolve that one in our committee. We can try. Certainly understand the differences of opinion around it, so we can consider it. But good point, Senator. All right. Any other questions? I've written that one down. Okay. So we have the flexibility bill in front of us. We got a short look at, and I was not in committee when House members were in the committee with you going through the section on audio only. So we will go through the bill and we'll spend some time today on audio only again with Jen. Then if we think we need to hear further from the House members and how those decisions were made, we can do that. So Jen, why don't you bring the bill up and we can look at that. And we'll do that for a little while. We will take a break at some point during the day because I do want to go through this bill and try to get to some, try to get to a place where we can consider a possible vote. Notice I said, consider a possible vote. So
are
okay.
you looking to go through the audio only language or to go through the underlying flexibility bill?
Let's go through the audio only first, and then we can go back through the whole thing after we've had a little break.
Yes, there's also a,
Oh, there's the informed consent piece.
there's the informed consent piece. Exactly. There's,
Okay.
thank you. That's exactly where I was going.
All right. I might turn my screen off for just a minute. Don't worry. I'm here.
All right, I'm just, hang on, I brought it up so that I could show you the language and now I can't find my document. So let's see where it went. It's right here. All right, so let's see. Now, there we go. All right. Okay. So this, again, as we looked at, I think Friday, this is the audio only language from the House. And I think we went through the language, but we can do that again if that would be helpful, or did we not get all the way through it? I don't frankly recall.
Did we
well,
go through it?
I don't know. Let's go through it and we'll see if it seems familiar. All right. So the first section is the health insurance side of things. And so this is coverage of healthcare services delivered by audio only telephone. And we have definitions of healthcare provider and health insurance plan, and the important piece that was added. And I think, as I mentioned on Friday, what's highlighted in green were changes that were made after the House Healthcare Committee had kind of voted out what they wanted to send over for this committee to look at. There were some additional issues that were brought up. And so I had just flagged these so that people who've been following along in the House could see what was different in this language. So the first piece here is that it still includes Medicaid, but just to the extent permitted by the Centers for Medicare and Medicaid Services, with that being very much in flux. So it requires a health insurance plan to provide coverage for all medically necessary, clinically appropriate healthcare services delivered remotely by audio only telephone to the same extent that the plan would cover those services if they were provided in person. And the services would include services that are covered when provided in the home by home health agencies. So I'll just pause here for a second on the clinically appropriate, and certainly you should hear from providers and the provider community. Not being a provider myself, I'm still going to wade in with what I think is hopefully a helpful example of something that to me doesn't seem like it would be clinically appropriate. And that would be something like audio only telephone to diagnose a rash. I think it would be difficult without the visual element there if somebody's, or a growth or something that's on somebody's body that requires somebody to look at it that seems like it might be in the area of something that would not be clinically appropriate for audio only telephone. I'm sure there are some exceptions to that, and that's of course why it would be helpful to hear from the providers, but just to give you a little bit of context for something that might explain why things aren't always clinically appropriate for telephone. Similarly, anything that might involve, manipulating the body or something like that could be difficult to do by audio only telephone, although perhaps that helps lead to a referral or something like that. It requires, and then the second part is also important. So the first piece is provide coverage for all medically necessary, clinically appropriate healthcare services delivered by audio only to the same extent they would be covered if they were in person. And then the next piece, and this is second part, is time limited. Says a health insurance plan must provide the same reimbursement rate for services billed using equivalent procedure codes and modifiers, subject to the terms of the health insurance plan and provider contract, regardless of whether the service was provided in person or by audio only telephone. So the first piece is coverage. Second piece is same reimbursement rate, the reimbursement parity. And then subsection B, and this was something, or subdivision B, this was something that one of the payers had suggested, was to say that reimbursement parity piece shall not apply if the insurer and provider enter into a value-based contract for healthcare services that include audio-only telephone. So this idea of reimbursement parity really only makes sense in a fee-for-service context. And if there's a value-based contract, then it wouldn't necessarily hold people to the same reimbursement parity, because the reimbursement would be happening in a different way.
Madam Chair, can I ask a question about that?
Yes, go right ahead.
Okay.
Yep.
So Jen, the value-based contract, is that specific to providers who may be members of the ACO, or are there value-based contracts between payers and providers that are outside of the ACO situation?
To my knowledge at the moment, that is happening in the context of the ACO, and through the all payer model and through the Medicaid Next Generation ACO project. But don't hold me to that. There may be things going on that I'm not aware of.
Okay, I was just wondering to the extent how many of these contracts may be out there, and if we're only talking about the providers who are members of the ACO and the all payer model, et cetera, or if there are others, but.
Yep, and that's my general understanding. I think there was concern about potentially locking this provision in the reimbursement parity into a fee-for-service model while simultaneously looking to pursue more value-based payments. And so this would give an out, give kind of an exit ramp, so that there wouldn't be reimbursement parity required if payment wasn't being done on a fee-for-service basis.
Okay, yeah, I appreciate that. Thank you.
Sure. All right, then it allows a plan to charge an otherwise permissible deductible, co-payment, or co-insurance. So regular cost sharing can apply, provided that it does not exceed the deductible, co-payment, or co-insurance applicable to an in-person consultation. So you can't charge more out of pocket for the patient to get a audio-only telephone visit than they would if they were having an in-person visit. And then finally, a plan cannot require the provider to have an existing relationship with a patient in order to be reimbursed for healthcare services delivered by audio-only telephone. And this was the subject of some discussion in the healthcare committee, trying to balance what might be appropriate with a patient who'd never met with the provider before, and also recognizing some circumstances where, for example, someone might be new to the area and not have an established relationship with any provider, and be looking to receive services, and leaving that then up to the clinical judgment of the provider about whether it was appropriate to treat a patient by phone without having met them in person. All right, so that was the insurance side, the kind of how to get, what's covered and how do the providers get paid. And then the second section is looking at the providers, more focused on what the providers are doing and providers who are delivering healthcare services by audio only telephone. So we piggyback on the same definitions of health insurance plan and healthcare provider, and also the telemedicine definition from the existing insurance statute on coverage of telemedicine. So then it says, subject to the limitations of the individual provider's license and for Medicaid patients to the extent permitted by CMS, a healthcare provider may deliver healthcare services to a patient using audio-only telephone if the patient elects to receive the services in this manner and it is clinically appropriate to do so. A healthcare provider has to comply with any training requirements imposed by their licensing board on the appropriate use of audio-only telephone in healthcare delivery. So then it says a healthcare provider who delivers healthcare services using audio-only telephone must include or document in the patient's medical record the patient's informed consent for receiving services this way, and there are more provisions on that to come in subsection C, and the reason or reasons that the provider determined it was clinically appropriate to deliver healthcare services to the patient by audio-only telephone. So this is the piece we were talking about before, where they have to include or document in the patient's medical record why the provider thought it was clinically appropriate to use audio-only telephone to deliver these healthcare services. A healthcare provider shall not require a patient to receive healthcare services by audio-only telephone if the patient does not want to receive the services in that manner. So leaving a lot of choice to the patient as long as it's clinically appropriate to do audio-only telephone. And a healthcare provider must deliver care that is timely and complies with contractual requirements and shall not delay care unnecessarily if a patient elects to receive services through an in-person visit or telemedicine instead of by audio-only telephone. There had been some concerns raised by one of the insurers about providers potentially saying, well, we can either get you in today for tomorrow for an audio-only telephone, or you can come in 3 months. But there was also discomfort on the committee about trying to peg a specific number of days, which had been the request from the insurer, specific number of days that the provider must see the patient in person if the patient doesn't want audio-only telephone. So trying to kind of keep things flexible enough to reflect the realities of various practices, but also reminding providers of the responsibility not to delay care unnecessarily because somebody wants to come in or do telemedicine. So then we get to the informed consent parts. A healthcare provider who delivers services by audio-only telephone must obtain and document a patient's oral or written informed consent for the use of audio-only telephone prior to the appointment or at the start of the appointment, but prior to delivering any billable service. So it can be done ahead of, a day or two ahead of time or earlier that day, or it could be done right at the beginning of the appointment, but before any services are actually delivered.
Jen,
Yes.
you raise a question for me. Is there any provision in here, obviously the informed consent either orally or in writing means that it's being recorded somewhere. Is there anything in this section that requires an audio only, or in fact, probably not audio visual, but an audio only to be recorded as a record or a transcription as a record?
There's actually a prohibition on that, which you'll see coming up, and that's the same as what's currently in the telemedicine statute. I know there's been concern as far as patient confidentiality about making any kind of a recording of a patient visit.
But nevertheless, there'll still be summary notes and notes of the visit that would be required by the practitioner.
Right.
Okay.
Okay, so the informed consent for audio-only telephone, this is line 9, shall be provided in accordance with Vermont and national policies and guidelines on the appropriate use of telephone services within the provider's profession, and it must include in language that patients can easily understand First, that the patient is entitled to choose to receive services by audio-only telephone, in person, or through telemedicine to the extent clinically appropriate. That receiving services by audio-only telephone does not preclude the patient from receiving services in person or through telemedicine at a later date. And I'll just pause to say a lot of this is built on but modified from our existing telemedicine provisions as they relate to the provider practice and specifically here to the informed consent.
I have a question.
Yes.
So is there, I guess, I don't know who's going to answer this question for me, but if a practitioner denies audio only because it isn't clinically appropriate, and the patient disagrees with that, I guess I won't go there. I can see it getting
Right.
twisted.
I don't think there's a fair amount of patient choice here, but there is not the choice to insist on something that the provider believes is not clinically appropriate.
Yeah.
In that case, the patient could seek a different provider if they were looking specifically for audio only telephone. They could perhaps talk to the provider's office, or if they had real concerns that somehow it was inappropriate to have or unprofessional conduct to have refused the audio only telephone, they I suppose could go to the Board of Medical Practice or OPR. But I think it would be it's difficult for patients to succeed if the provider in their clinical judgment believes audio only telephone is not appropriate.
Senator Cummings, go right ahead. And you're muted.
So this would not allow a provider to say, look, I just don't feel comfortable diagnosing folks over the phone, so I'm not doing audio only.
No, it would. It's just the opposite. It would allow.
Well, no, so that's an interesting point. I mean, if it's clinically appropriate, but the provider doesn't want to do it, I don't know that this requires. I'm scrolling all the way up here. Let's see. So it's a may, subject to
May.
the limitations of
Okay.
their license. They may deliver services if the patient chooses to receive services that way and it's clinically appropriate to do so. But it is does not require them to. Oh, it's an interesting question because it hadn't come up. So I think if the patient really wants an audio only visit and a specific provider is not offering that, then it may be that they need to seek a different provider for that service by audio only. Yeah, Senator Cummings,
Go right ahead.
Reading.
Because I have a hard time seeing everybody.
Okay,
Senator.
this is Ann. I have another question. I have a family member who has been receiving a lot of medical care lately, and there has been a lot of phone calls like, this combination of meds isn't working, can we try something else? Or I'm having this reaction to this chemo, is that normal? What she said to me is, if I got charged a $30 copay every time I called, I would call a lot less. I would put up with a lot more discomfort. This doctor says, if you've got any questions tomorrow, call, and does not charge.
Right.
But is there anything that says, so next week for that same call, I can get paid for a full office visit?
So
Is
my
there-
understanding is no, and in part because those are sort of more the telephone triage calls that are to determine if an office visit is necessary. But I think that would be an important question for you to hear from others on. I don't know that
I'm concerned
capable
about
of-
what
Yep,
we may
and
be
the House
doing.
and the House committee definitely had similar concerns. And I think there was some explanations of how that would or would not apply. But I think you'll need to hear from others, and it may be about what the coding is. But I think it would be important to hear from either the provider or payer community about what what the consequence or what the implications are for the patient and the cost sharing. I mean, we do get to a piece here about letting them know whether the services will be billed to the patient's insurance plan if delivered by audio-only telephone, and what this may mean for the patient's financial responsibility for co-payments, co-insurance, and deductibles. So that's sort of the informed consent part of it. If it is going to result in a bill to the insurance company, then the person would be told about it. But I understand the concern you're raising about the potential chilling effect on patients seeking information from their providers because they're concerned about the cost sharing implications. And I
So
don't have
the-
a clear answer.
Yeah, well,
I think I've been clear that I'm concerned that no insurance committee has looked at this bill. I have told leadership I'd like finance to see it because this is a major new service. We have asked health insurance providers to do away with co-pays and all kinds of services related to COVID. But eventually that bill is going to have to be paid. And I want it, health insurance and telephone calls don't do you any good if you can't afford it. So I think someone needs to look at the potential cost implications here.
so I would, two things. We'll get to the question about that second, but in the first instance, if is there anything in this bill that suggests that coding will be changed? So
Yes, that's coming up in section 3.
okay, so we'll look at that. So let's get through the entire bill before we ask the urgent question of, is this going to extend all the copays ad infinitum? So that's one. Two, it does suggest to me that having an all-payer model will obviate some of the questions that we're hearing. And then on the question, Senator, of whether and how finance might evaluate this, I think let's go through the whole bill, and then we should probably talk about how that can happen, given that it's now, we're looking at it as integrated into the flexibility bill. So
That's my concern. The House could do this as a committee bill,
yes,
which
they
was
could.
one of the options,
Yeah.
because I'm not sure you want this in something with the time sensitivity that flexibility has.
Well, remember that the time sensitivity for audio only is there, given that we're in an emergency. So the question is, do we do it twice? Do we do it 3 times? And so we'll have to,
Right.
we'll be talking.
This does it until, I believe, 2025. So it's not,
That section does, but there's nothing in here that says anything about extending it until June 2022. Then that would mean coming back and ensuring that there's some other deadline that takes it further, because we know audio only has become a part of patient access. So we'll have to talk about that offline, I think.
it'd be interesting to know how much new audio only has been being booked.
Right, and I think that's an issue with data collection that we get to in the next section as well.
Yeah.
Because there has not been consistent coding in a manner that allows, outside of Medicaid, allows for the collection of that data. So section 3 would require that to happen with information being presented back so you can make a long-term decision.
Senator Hooker has a question.
I seem to remember in some conversation talking about payment for audio only. And if the patient then subsequently had to go into the office and have an in-person call, that wouldn't be a double charge. Is that
Right.
anywhere
I
in the
think
bill?
that's the telephone triage piece.
Okay.
Which is addressed in a sense by allowing DFR to continue adopting emergency rules in that area. But that is my understanding of the practice, and I think what is also in DFR's current emergency rule, that if it results in an office visit, that just gets kind of rolled into the office visit.
Okay.
Senator
Thanks.
Terenzini.
Thanks, Senator Lyons. I'm trying to follow along here, and I'm on our Senate Committee Health and Welfare page. I can't find the exact 10-page document that Jen is presenting. Can someone point me in the right direction?
Maybe up for Friday if it isn't up from today.
Okay,
Oh,
I'll go to
it's there.
Friday.
No, it's there.
Well,
It's
all
on-
the,
It says, under Jen Carby, there's a draft with numbers after it, 4.1.
yeah.
Well, I don't know if that's that may be the flexibility bill.
That's what we're talking about.
No, right now we are looking at the audio only language,
Oh, so it's
which
on
is a
Friday.
separate document,
Sorry,
right? But I
Okay,
think
so
you
if I
can
look
find
at,
it under Friday.
if I look at Friday, I should be able to find it. Okay.
Yes, it'll probably say draft 3.3 because I think I made a formatting change since then and made it 3.4 just so there's no confusion. But
Okay.
not a substantive change.
Sorry about that.
Yeah,
All right.
No problem. I found it. Thank you.
Great.
And Madam Chair, I don't know if you saw that note that Nolan just sent about there may be a fiscal note with the audio only section to address some of the questions about cost.
So we'll get to that. Let's get through the bill first and then we'll get to that. Thank you. That's good. I mean, we got a lot of questions that have been piled on in the middle of the bill. We want to make sure that we get through all of the sections and then absolutely we need to ask the question about a fiscal note. And then how this section goes forward. So Jen, can you remind us where we are?
Sure, we are looking at the requirements for informed consent.
Uh-huh.
So there are a number of things that the informed consent has to include. The first two that we went through were that the patient is entitled to choose to receive services by audio only telephone, in person, or through telemedicine to the extent clinically appropriate. But again, we're already at the informed consent stage, so the provider is presumably willing to provide audio only telephone services. The receiving services by audio only telephone does not preclude the patient from receiving services in person or through telemedicine at a later date. An explanation of the opportunities and limitations of delivering and receiving healthcare services using audio only telephone. Informing the patient of the presence of any other individual who will be participating in or listening to the patient's consultation with the provider and obtaining the patient's permission for the participation or observation. And finally, this one I shared a few minutes ago, whether the services will be billed to the patient's health insurance plan if delivered by audio only telephone, and what this may mean for the patient's financial responsibility for co-payments, co-insurance, and deductibles. This would not likely be specific information about that patient's expected co-payment or co-insurance, but more what it would mean for their exposure. Without knowing where the patient is in their deductible, for example, it would be hard to know for the provider to know whether they would have the co-payment responsibility or not. But it at least alerts them to the potential. For services delivered by audio only telephone on an ongoing basis, the provider only has to get the consent at the first episode of care. So for example, if this is a weekly mental health counselor treatment, then they don't have to do this informed consent at the beginning of every session, but just at the first episode of care. If the patient provides oral informed consent, then the provider must offer to provide the patient with a written copy of the informed consent. And then notwithstanding any provision of this subsection to the contrary, a healthcare provider is not required to get a patient's informed consent for the use of audio only telephone in the case of a medical emergency. And a healthcare provider can use a single informed consent form to address all telehealth modalities, including telemedicine, store and forward, and audio only telephone, as long as the form complies with the provisions of Section 9361, which is the previous section on, and it deals in statute dealing with telemedicine and store and forward, and this section. So they can use a single form as long as it complies with all of the statutory requirements. And then this gets to what the chair had asked earlier. Neither a healthcare provider nor a patient shall create or cause to be created a recording of the provider's telephone consultation with the patient. And this is the same provision that applies with telemedicine as well. And then finally, audio-only telephone services shall not be used in two circumstances: for the second certification of an emergency examination, determining whether someone is a person in need of treatment for mental health purposes, or for a psychiatrist's examination to determine whether someone is in need of inpatient hospitalization. Again, these are both in the emergency psychiatric mental health context. Then we get to section 3, audio-only telephone, medical billing, and data and collection and a report. So this would say that by July 1st of this year, the Department of Financial Regulation, in consultation with DEVA, the Green Mountain Care Board, representatives of healthcare providers, health insurers, and other interested stakeholders, this is where they would determine the appropriate codes or modifiers or both to be used by providers and insurers, including Vermont Medicaid to the extent allowed by CMS, in the billing of and payment for healthcare services delivered using audio-only telephone, in order to allow for consistent data collection by insurers, maintain reimbursement rates equal to those for in-person services, identify appropriate codes for services that do not have in-person equivalents, and minimize the administrative burden on providers. To the extent possible, the use of codes or modifiers or both would be done in a manner that allows data on the use of audio-only telephone services to be identified using VCures. So that's the first piece, that by July, DFR, along with, after consulting with all these others, would come up with a consistent set of codes and modifiers so that everyone's using the same codes, both for the billing side and for the payment side. And then this would require not later than January 1st that all Vermont licensed healthcare providers and health insurers who offer plans here would use the codes and modifiers determined by DFR under subdivision 1 when delivering services by audio-only telephone, and that Vermont Medicaid would participate to the extent permitted by CMS. So this gives a bit of time for people to start using these codes between July 1st and January 1st. The idea being that everyone would be using them not later than January 1st so that there can be data collection for the 2022 plan year. And I think we had talked on Friday about why it might be important to collect data over the course of the whole plan year, because people's behavior may be different depending on where they are in the plan year. Then on or before December 1st, 2023. So this is the plan year goes through the end of 2022, but then there's sort of the claims lag and the data collection that continues into 2023. So then this information would be by December 1st, 2023, DFR, VPQHC, the Vermont Program for Quality in Healthcare, and to the extent VCures data are available, the Green Mountain Care Board would present information to this committee and the Senate committee and the House committee, and you may want to add the Finance Committee, regarding the use of audio only. What?
Commerce in the House does insurance.
They don't do
Doesn't
health
it?
insurance. Nope, House Healthcare does all health insurance. Commerce does all other forms of insurance.
Okay, they do all other insurance.
Yep. And the department must consult with
I'm sorry, I was going to make a comment.
Oh, sure.
I continue to be concerned that our health insurance regulation is bifurcated, which is why I tried to, I had a bill in last year that would have put some of this back into rate setting into the Green Mountain Care Board, where that can take place that by statute. So I think health insurance should be fully integrated together. And I know that we have Medicaid services and we have private insurance. And for me, this is one of the big areas of problematic areas that we have in trying to make any decisions about payment reform or access reform. So that's my bias. Sorry, Jen. I'm not sorry. Please go ahead.
All right. So the DFR would consult with interested stakeholders in order to include in its presentation information on utilization of audio-only telephone services, quality of care, patient satisfaction with receiving services by audio-only telephone, and the advantages and disadvantages of the reimbursement parity provisions. So that's the data collection, sort of figuring out how to do consistent billing or consistent coding so that data can be collected so you can have apples to apples comparisons. And at least some of that hopefully in a non-pandemic time period to understand how people are using audio-only telephone services outside of a pandemic. And then collecting that information on utilization, but also the patient satisfaction and quality pieces and on the reimbursement parity. So, and then we'll look at the sunset on reimbursement parity in a moment. But meanwhile, we do have this piece, section 4 on the telephone triage services, and this would allow DFR to consider adopting and have the authority to adopt. So same language we use in the other DFR rulemaking piece in the COVID flexibility bills, emergency rules to address health insurance coverage of and reimbursement for telephone calls used to determine whether an office visit or other service is needed. So this is a piece of what DFR already has rules on, the telephone triage piece, but this would keep that part going under the existing DFR authority. And emergency rules adopted pursuant to this section would remain in effect until not later than April 1st. So run through the March 31st, 2022 date that you have in the rest of the COVID flexibility bill. Then we have kind of a conforming piece in section with just section 5 here, and this is in the health insurance coverage for telemedicine in the reimbursement parity language that is in that existing statute. This would say that they don't have to do reimbursement parity in the event that a health insurer and healthcare provider enter into a value-based contract for healthcare services that include telemedicine or by store and forward means. So that was, again, is saying if we're looking at a value-based contract situation, I feel like there's a grammatical issue, so let me look at that piece, but that they don't have to do reimbursement parity if it's not fee for service. Then section 6 is the sunset on the audio-only telephone reimbursement parity. So way back at the beginning, when it set up that reimbursement parity, this says that provision is repealed on January 1st, 2025. So the information comes back to you in December 2023, going into the 2024 legislative session. That gives the legislature that 2024 session to determine whether they want to extend the reimbursement parity, allow it to sunset, or do something different with audio only in general. I saw there was a question, then to expect on passage, then I'm done.
Yeah, Madam Chair, I have a question about that date.
Go ahead.
January 21st, 2025. I think I read in the audio only report that the recommendations from that report were that this would extend through 2024. So January 1st, 2024. And I'm wondering why the extra year and what the House committee may have discussed in order to extend it out.
Right, so that's what I was trying to get at here. It's really because of the data collection and the lag. So January 1st, 2025 means through the end of 2024. And so this allows you to, after getting this information just before the 2024 session starts about utilization and about quality and patient satisfaction and reimbursement parity, you get all of that information just before the 2024 session. Presumably you or whoever is in your seats in 2024 spends time during that session revisiting this issue of audio only telephone, whether it's working as intended, what the utilization looks like, whether to keep reimbursement parity. And then if you do nothing, then the reimbursement parity ends at the end of 2024. But if you wanted to change that, you would have time during the 2024 session to revisit this January 1st, 2025 date.
Okay, so did the audio only report not have the data collection sort of time period in it? Or how did they back it up to a year.
I'm not entirely sure how they came
Okay.
up with their recommendations for how long things should continue on. I think there may have been some interest in just allowing DFR to continue regulating in this area. And this language takes a different approach and puts provisions in statute, both around parity and also reimbursement and insurance coverage, but also around providers and informed consent and a number of things that go into more detail than what DFR could do by rule.
Okay, thank you.
Yeah, the timeline, I think, is pretty critical in terms of having the data to support any changes that are made. The difficulty that we're facing right now is that there are concerns that changes are being made before the data is available. So we're in a catch-22. How do you have the data available if you don't allow for the data to be made available? And so the conditions I think that the House has put into the bill are trying to ensure that we don't see, that we do see sort of what I will call the appropriate use of audio only, and not have it become unferreted appointments and charges for co-pays and so on. So it's not a simple process. It's more complicated, I think, than saying audio only. And so I think thinking about this timeline is important, and how the data is being collected, that the data is being collected is also very important. And I don't know, we don't know, we're gonna have to hear from a couple of people, but do the insurance companies want to collect this data for us? I don't know. How is it going to be collected on the feet on the ground level by providers? So there are a lot of questions to ask, so we know that the data that's being collected is going to actually inform the final decision. So, Senator Hooker.
Thank you, Madam Chair. Jen, I had a question. You mentioned that in case of emergency, there was no informed consent necessary. I'm wondering how does that play out? I mean, if someone calls the doctor in the middle of the night with some emergency, is that treated as a call, an appointment, or is it treated as triage? And then tell them to go to the emergency room, so they're not being billed for that. So I just don't understand what you mean when you say in case of medical emergency.
It's the same language we have under telemedicine as well. If there's some exigent circumstances in the patient, and it's the most important thing is to deliver the service to the patient without taking the time to go through the informed consent process, then they do not have to.
Okay, and if it's found that that is inadequate and they're sent to the emergency room or to the hospital, whatever, then again, it goes back to the triage form or the triage section, so that they're not charged for a call.
That would be my understanding, but these are questions that you should probably ask of the payers or the providers.
Okay, thank you.
Yeah.
Senator Lyons,
Terenzini, go ahead.
yeah, thank you. I'm looking through it, Jen. Do you know which page the section was that you talked about when a patient does not need to see the doctor for the first time? In other words, you could call a doctor and not have any relationship with that doctor and still be seen by telemed.
Yeah, so that's actually on page 3, and it's in the end of the insurance piece. So it says that the plan can't require a provider to have an existing relationship with a patient in order to get paid for the visit. It doesn't, but then again, it's going to be up to the provider to determine whether it's clinically appropriate for them to treat a patient that way. But it's really about the insurance plan not standing in the way of that.
So I appreciate that. I to the committee, I totally support audio only. I support the reimbursement to the medical providers, but I think that's a sort of a dangerous line to walk. And I think most doctors, I would think, would require at least an in-person visit before they would consider audio only for someone that they don't know. I could see how someone could just start a doctor shop and have phone conversations or attempt to have phone conversations without that doctor having any personal relationship with them. I would think that could become a big problem. So
we probably, it sounds like we're going to hear from a couple other folks on this. This bill is not, this section of the bill is not going to be accepted by us until we have questions answered. I think that's what I'm hearing from everyone. And legitimate questions. I will say that I've had a lot of experience with what we're talking about in terms of triage and first-time patients and so on. And also, the question is too about the contracts that we don't see. And there are contracts between insurers and individual providers that sometimes really, I've seen some that really impede the provider's ability to, for patients to access the provider. So, we want to be very careful that we don't throw any babies out with bathwaters in all of our conversations. Access is critical. So, and this is a new era of, for audio only. All right, so committee, we also have an opportunity this morning to go through the nurse compact bill again. But I don't want to leave this one just yet. Are there other questions that need to be answered? I've heard a lot of them, and Senator Cummings.
Okay, I still have the questions about the impact on the cost of health insurance. And also, what happens if Medicare and Medicaid end their payment at the end of the declared health emergency? So then we're only roping in those private insurance, not all the ERISA plans, and the impact on the actuarial balance, if there's any impact, on the exchange plans. There's a whole lot of cost implications. I just need to hear about if you don't want it to go to finance.
Well, we do have to hear that. I agree with you. And so, Jen, in terms of the language that we have in this proposal on Medicaid and Medicare, can you scroll to that section where it talks about the Medicaid, Medicare?
Well, there's nothing about
Restrictions.
Medicare other than it being part of CMS's official name is the Centers for Medicare and Medicaid Services, but we haven't done anything in here relating to Medicare. As far as Medicaid, there are a number of provisions specifying that provisions relate to Medicaid to the extent permitted by the Centers for Medicare and Medicaid Services. So to Senator Cummings' point, if it is not permitted by CMS, then Medicaid would not be included. And if CMS was also not including Medicare, then it would be really the exchange plans, the reflective plans, and the small amount of the market that is large group commercially insured. That's who would be.
If the QHP is subsidized through Medicaid, then those plans would also be eliminated.
No, those are not subsidized by Medicaid.
Okay.
It's in our world, it's through DIVA, but it's DIVA wearing their QHP hat. It's DIVA as the operators of the Vermont Health Benefit Exchange. And we do get federal match on our state piece of the premium, but again, that's through an agreement with the federal government. It's not relating to what is covered under the plan. It's really the CMS piece here is really as it relates to Medicaid.
Okay, so we'll reach out to Nolan and maybe have Nolan reach out to folks regarding the cost implications. as far as we know them, because we don't have the data. I mean, this is one of the neat things, right? It's hard to put a cart or a horse anywhere with this thing and feel comfortable. But it is, in the long run, having telephone access, audio only access, it may be critical for patients. So. All right, any other questions or concerns? All right, so
Did you
Jen,
want to, yes.
go ahead, ask me that.
Oh, I was going to ask if you wanted to look at the informed consent piece on the telemedicine side in the flexibility bill.
Yes, let's do that, please. Then that's a different document. That's the document
Yep,
from
Exactly.
today.
Take
I
that
have
one down.
Yeah. That's the
Now put-
4.1 draft.
Yes, exactly.
Yeah. Okay.
All right. So I've pulled right up to the affected section here. So this is just to orient you. We're into the COVID flexibility bill where we've been extending a number of provisions from Act 91 and Act 40. One of those deals with telehealth, really the telemedicine and store and forward. And so what has been in here that you have looked at so far has been saying that extending through March 31st, 2022, certain provisions related to the delivery of healthcare services through telemedicine or by store and forward means is not required to the extent their waiver is permitted under federal law. The first two deal with HIPAA compliant connections and recognizing the enforcement discretion that the federal government is exercising around using HIPAA compliant connections to deliver services by telemedicine. So the first one is waiving or allowing flexibility on delivering services using a HIPAA compliant connection. And the second is representing to a patient that the healthcare services will be delivered using a HIPAA compliant connection. So those two pieces, House Healthcare did not have suggestions on, but they did have a suggestion that I've put here in green to put a time limitation on not requiring getting someone's oral or written informed consent for the use of telemedicine if obtaining or documenting the consent or both is not practicable under the circumstances. And instead of having this automatically go out until March 31st, 2022, the recommendation from the healthcare committee would be to end that 60 days after the end of the declared state of emergency in Vermont as a result of COVID.
Okay, and how are we defining that? I mean, that does
It's
open,
the end of the governor's state of emergency. So
I
60
know,
days
but it
after. the
does
end of the
open
governor's
up
state of
that
emergency.
whole question again about communication and so on. Okay. Maybe I'll touch base with Lori Houghton, who was the lead person or on the proposal that came to us. So figure that one out. All right. Questions on that? I do have a question. So the bill does include language regarding HIPAA compliance, and as the emergency ends, and we know that CMS is going to have something to say about reinstating HIPAA compliance going forward. And that would then include audio only, I would think. So,
Well, there isn't a HIPAA compliant connection requirement for audio only. It's not. I don't believe there is. Well, I won't. I
yeah, I
won't
don't know. I
speculate on the relationship between telephone service and HIPAA compliance, but I think there are some distinctions between information that is transmitted through the internet and information that is transmitted over phone lines. And you may want to hear from others on that, but I have not heard any issues about needing to put HIPAA compliance provisions into the audio only language.
Okay. Don't want to stir up a hornet's nest if it's not there. Okay, thank you. Any other questions? All right. Senator Hardy.
I just wanted to know the sort of timing issues here, because it seems like we're nearly ready or in agreement with the extension of the emergency provisions, and we have a lot of questions that remain about audio only. And I know that ideally you, Madam Chair, would like to have them blended into one bill. But I'm wondering, what is the timeline that we need to pass the other bill in order to make sure it gets through the process in time to meet the deadlines?
So we're working on that, and we'll try to get some testimony in to allow for us to make a decision about, do we want to send this back to the House to have a committee bill? They're ready to act on it. Or do we want, as we hear more testimony, will we feel comfortable and will we have some reassurance that the bill can go forward? So that's part of the process. Crossover will be in a couple of weeks, and we'll have to be ready for that. All right. Any other questions for Jen? Okay, Jen, I think we're not going to go through the flexibility piece again. The only piece that is outstanding is on the 60 days after the end of the emergency on informed consent.
Right, and then I have a sort of a placeholder in there highlighted in green also for the audio only piece, just to remind us that it's currently in there in one form and should be addressed.
Okay. All right, we'll work on getting to some, to closure ASAP on this bill. I don't want to hold it up any longer than necessary, but we also don't want to prolong the agony. Oh. Okay, thank you for that. And I know that, I think Amarin is here. She was here. Nellie, is Amarin still around?
She stepped back out. I can email her and get her back in.
All right, let's do that. And while we're waiting, committee, let's take a 5-minute break. So come back around 11:27, 28 in that area, and we will pick up on our nurse compact bill one more time.